In our paradigm of our head and neck cancer patient, we've gone through some of the diagnostic expectations for our patient. We're going to continue in our treatment paradigm and then move into our rehabilitative process. So, for our treatment paradigm, as we start to navigate and explore, we have taken the particular patient who has a base of tongue primary site. They are being treated with definitive chemo-radiation therapy. And we have gone through modalities of different numbers of treatments and side effects. So let's talk for a moment about the expectations related to trismus. What in the world is trismus? Trismus means I have trouble opening my jaw. So number one, I define it for my patients. I show them. The muscles of mastication include the masseter, the pterygoids, the temporalis. So there are four key muscles in our patients to help them with chewing and mouth opening. Masseter, pterygoids, lateral and medial, and temporalis. These muscles all work together to help with an expected chew pattern, including a rotary chew. And when those muscles are impacted by the fields of radiotherapy, guess what happens to them? They become inflamed, they become mad, they become damaged, and these muscles are progressively going to worsen. Now, I have a personal sort of education opportunity that I am always trying to share with therapists. We expect around a 30% decrease in our patient's mouth opening during the course of their treatment. It is very important to know if you are trying to actively stretch open your patient's mouth during treatment, you are going against the side effects of the natural healing process that your patient is going through. So during the course of my patient's treatment, typically I am going to see changes in their mouth opening directly correlated to an inflammatory process. So if my patient is experiencing mucositis, inflammation, if my patient is experiencing side effects of dry mouth, if my patient is experiencing sores, if they have erythema, they are all going to be inside the buccal cavity, the buccal lining, the mucosa. If it is lining the oral cavity or the tongue, those are going to be barriers for my patient to decide they want to open their mouth. I am going to share with you that in one particular case, one of my patients forced their mouth open during their treatment and split right here the lining of the oral mucosa. Very mad, very frustrated with me for weeks because the healing process during radiation, when we force active range of motion, takes much longer following their treatment if they have open wounds. So our goal as therapists is to teach our patients about trismus. We measure their mouth opening. Every single time they walk in this door, their mouth opening is measured. We find out where they are in their process, and if they decrease in their mouth opening during treatment, let's say they started at a 42 and they decrease 30% for 812, right? So they're going to decrease a good amount. If they're decreasing, let's say they go to a 34, a 35, and they're in week 6 and 7 of their treatment, I am not panicked. I am saying to them, let's continue some passive range of motion to help with circulation, to help with lymphatic flow. Your body is trying to start to heal. You are going through the natural processes of radiation. We are not going to force the mouth open. We are not going to actively stretch. That's a no-no during treatment. We are going to passively open the mouth, shift the jaw, and do the things that your body allows to do, considering I am a provider who understands this word, who has been educated in this field and understands the severity of if I decide to treat this diagnosis without the proper knowledge, I absolutely can damage my patient for life. And I do not say that lightly, okay? If you treat trismus and you are not skilled in trismus, you are doing your patient a disservice, and a huge one. As speech pathologist, there is a course that I love, and I happen to be the owner of it. The course is called the ARC-J course. That helps us as speech pathologists understand exercise physiology. The course was created by two speech pathologists, Megan and Brian, who did a phenomenal job in being able to help speech pathologists start to navigate the world of exercise science. I took over the course a couple of years ago as they both moved in different directions. And the course for speech pathologist is a foundation in understanding the role of radiation, the association for trismus, and how to help these patients. Now, here's one thing I want to talk to you about. Physical therapists are just better at this than us, and it's okay. However, we are the ones in their mouth, so this can be a collaborative approach. Trismus is a side effect. It means I can't open my mouth. 35 or lower is the actual number. That's with dentures in place, teeth in place. If you don't have teeth, there's ways to measure that, etc. So, trismus means my mouth opening is 35 millimeters or less. We always measure in millimeters. I need to know, as a therapist and a speech provider, I expect my patient's mouth to get worse during their treatment, about 30% worse, and then it is going to improve once the acute side effects of their treatment have resolved. So I will begin active range of motion with my patients who have and demonstrate trismus or difficulty with opening the mouth about 12 weeks post radiotherapy. So what do I do for my trismus assessment during the course of these 1 through 7? I have a checklist. I measure their mouth opening. So measure, okay? The next thing I do is, when I am measuring their mouth opening, I also am considering, are they going to benefit from a device? If yes, we understand that trismus is a device-driven protocol that is indicated 3 months following their therapy. I'm going to begin to order that device for that patient so it's ready to be used, and I'm not waiting on insurance or anything else that could get in the way. So I measure my patient. I teach them passive versus active range of motion. I teach them those words. What's the role of passive range of motion? What's the role of active range of motion? Which one should you be doing? And why? I also will individualize their treatment plan based on TMJ, joint history, reconstruction, anything that patient has been through. I will begin to individualize that trismus intervention plan. So we know the timing of treatment, we know when it gets worse, we know when it can improve, and we know when we can stretch it. Again, all evidence-based practice that is within our paradigm for treating our head and neck cancer patient with wildflower therapy.